Hello, 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 ladies and gentlemen. Hello. Today we are talking about the topic of substance abuse. And before I get started, I just want to say a few things. Please remember, please remember that substance abuse is a disease. The individual or the patient has done something, whether it be recreationally, prescription med, experimentation, for any number of reasons. Um, Partying, to be social. These patients, these individuals have done something. And then because they have done one thing, there is sometimes a domino effect. And so what we end up dealing with is a sick brain, a diseased brain, and a sick body. And because of that, we need to remember as nurses that we are healthcare providers, which means that we need to approach this patient, excuse me, without judgment. There can be no judgment because everyone has a story. Now, with that being said, should you come upon this patient, and because everyone has a story, and this is not something that is isolated. And sometimes we bring our personal thoughts, experiences to caring for a patient. So I respectfully ask you that if you have an experience or knowledge that would preclude you from taking care of this patient, this individual, without judgment, what I would ask you to do as a nursing professional who is looking for the best possible outcome for their patient and looking for the best way to care for this patient. If you need to, please step back, step off, follow your chain of command, go to your charge nurse, go to a supervisor, and simply state that because of whatever, XYZ, you do not feel that you could adequately care for this patient. Offer to take another patient, offer to do something else, but you need to put this patient's care above anything else, the same way you would caring for a cancer patient, a diabetic patient, any other patient with any other disease process. So I respectfully ask you to remember that this is a disease process. And because it is so prevalent, may have a story, or may know someone, excuse me, who has a story. Maybe there's a family member who has a story. Please know that I am trying to address this topic as respectfully and as carefully as I can, not looking to offend anyone. I am just looking to educate you on how to care for this population. So, with that being said, let us move on to the class outcomes. So, the class outcomes are to recognize the role of the nurse, you, the nurse, in providing care to patients with substance abuse. Analyzing the medical complications of alcohol dependence. Now, this should not be new because last semester when we were doing hepatobiliary, we did talk about the effects of alcohol on the liver and on the pancreas. differentiate the presentations of clients abusing various substances, and utilizing CUSIN standards, formulating a nursing plan of care for an individual with a substance abuse disorder. So, a substance use disorder is the use of a substance in the amounts that are harmful to the user or others, affecting individuals, families, and society. Substances such as illicit drugs, alcohol, and tobacco are used for varied and complicated reasons. The individual with a substance use disorder may neglect important obligations or role responsibilities at home, school, or work as they get further and further into their addiction, into their disease process. Legal consequences will often include driving while intoxicated, possession of illegal substances, public intoxication, domestic altercations, and other behaviors related to poor judgment. The substance use may continue even when the substance user is aware of actual and potential negative consequences. This is when the individual has gone so far down the road that they are no longer able to control their use of whatever substance they are abusing. The substance that they are abusing is now controlling them. We are dealing with a truly sick individual. The diagnostic criteria for substance use disorders. The fact that there is diagnostic criteria should tell you that this is a disorder, this is a disease process. So, in the Diagnostic and Statistical Manual of Mental Disorders, abuse and dependence are defined as diagnoses. Abuse is diagnosed with any recurrent negative consequences from substance use, such as occupational, social, or legal problems. Dependence is considered a more severe form of substance abuse and usually includes the development of tolerance. Tolerance is when we need more of a substance to get to the desired effect. So what does that mean? That means that if I come home from work and I have a glass of wine with my dinner, and now after dinner, I am feeling very relaxed, maybe because of the food, maybe because, relaxing with my family, maybe because I've had a glass of wine. And so I'm like, okay, and I can hang with that glass of wine for a period of time. And then perhaps I have a really stressful day, an incredibly stressful day, whether it's at clinical, at school, a family issue, doesn't matter. But I come home, I'm having dinner with my family, I have my usual glass of wine, and then I'm like, you know what? Usually I feel so relaxed, after dinner, after my wine, you know, one glass, yeah, let me just have one more. And so now I build up a tolerance to that one glass of wine. So in order to feel a little relaxed, a little mellow, not caring about the day, maybe now I need two glasses of wine. That is tolerance. And the diagnosis of substance use disorder will replace, abuse and dependence. So we are no longer using those terms. So substance use disorder is not an actual diagnosis. Is it a broad term to describe any of the individual or collective SUDs? For example, the individual who consumes alcohol excessively might be diagnosed with an alcohol use disorder. The individual who will use cocaine and alcohol excessively could carry two diagnoses because we are talking about two different substances. So that would be an alcohol use disorder and a cocaine use disorder. So the essential feature of an SUD is described as a cluster of cognitive, behavioral, and physiological symptoms, indicating that the individual continues using the substance despite significant substance-related problems. So, for a diagnosis of an SUD, the pattern of substance use must be problematic, must be associated with clinically significant manifestations, and at least 2 of the 11 possible clinical manifestations or criteria must be present. Now, there is a table on page 1719, table 70.1. So if you want to just take a look at that table, you are not responsible for this table. You do not need to know this table, but I just want you to take a look at it so that you can see that there is criteria that we use because this is a diagnostic issue. This is a disease process. The severity of an SUD is determined by the number of clinical manifestations present. So mild would be 2 or 3 clinical manifestations, going back to that table. Moderate would be 4 or 5 clinical manifestations, or severe, which would be 6 or more clinical manifestations. So the specific substance used is included as part of the diagnosis. An individual who uses marijuana has the diagnosis of cannabis use disorder if the marijuana use meets the criteria for an SUD. Because remember now, just like alcohol in many places, in many states, marijuana is legal. So it is only when the person is abusing marijuana the same way they would abuse alcohol, even though both are legal, that would lead to a disorder. Tolerance, withdrawal, and craving. These are 3 clinical manifestations of physical dependence. They are also clinical manifestations that may be evident with the diagnosis of an SUD. Dependence occurs because the body naturally adapts to regular exposure to a substance, meaning that I have become dependent upon it. So, and we see this in many areas of life, right? We see this because we may be dependent upon our coffee in the morning. When I get up in the morning, the first thing I like to do is head right for my coffee pot because I want to grab my coffee and start my day. Now, could I live without getting my coffee first thing in the morning? Yes, I could. And that is evident because, sometimes I need to have labs drawn first thing in the morning, and so I have to be fasting. So what I do is I will still make my coffee the night before to brew in the morning. I come downstairs and I will prepare my coffee. I don't drink it, but I prepare it, put it in a to-go cup, and I will take it to the lab with me. So as soon as those labs are drawn, I can have my coffee and start my day. Maybe if you're a smoker or if you're somebody who vapes, maybe you're dependent on that. Or maybe you are dependent on something that is more insignificant or more healthy, meaning that maybe you're one of these people who, when they wake up first thing in the morning, they have to get their exercise out of the way. They have to get their run out of the way. They have to get their walk out of the way. They want to get to the gym before they do anything to start their day. They are dependent on that to start their day. The adaptation may lead to tolerance, withdrawal, or both. So when tolerance develops, more of the substance is required to achieve the same effect. So let's go back to my wine with dinner. For example, the individual who consumes alcohol to feel euphoria or happy, relaxed from 2 beers will now need 5 beers to get to the same effect. If a person who has an AUD has developed tolerance to alcohol, the person may be able to walk and talk with a blood alcohol level, otherwise known as a BAL, that would seriously incapacitate the inexperienced drinker. Now, I'm a wine person. I am a wino. So my tolerance, quote unquote tolerance, for wine would be a lot higher than it would be, say, for a mixed drink or an alcoholic drink, because that is not what I am accustomed to drinking. So if someone were to hand me a Manhattan, for instance, that's made with bourbon, or I think it's bourbon or whiskey, whatever it is, one would, I wouldn't say that it would capacitate me, but I would certainly be feeling the effects of the alcohol a lot sooner than I would after a glass of two of wine. Withdrawal is the occurrence of physical or emotional clinical manifestations if the substance is decreased or abruptly stopped. Those uncomfortable withdrawal manifestations are usually the opposite feelings from the desired effect of taking the substance. For example, the desired effect from alcohol might be to relax. So the withdrawal clinical manifestation from an AUD is to feel anxious. I'm going to feel tremulous. I'm going to be irritable. I might be argumentative because I have not had that alcohol. The desired effect from cocaine might be to feel alert and euphoric, happy, energetic. The withdrawal clinical manifestations from cocaine use disorder are dysphoria. And dysphoria is the feeling of feeling unwell. I am unhappy, emotional, and I have mental discomfort, meaning I am just not feeling right. I am just not feeling right in my head. I am just not feeling right in my body. Depression or sleeping. Physical dependence may lead to craving. Craving is a strong desire or persistent thought about the substance. So, physical dependence may lead to cravings, which may be triggered by external or internal factors. External triggers may include a place, a specific bar I go to, or a specific person that I usually have my drink with, people or things associated with the substance use patterns of the substance user. Internal triggers will include emotional or physical symptoms of withdrawal, and then physical dependence is a separate condition from SUD. So, ladies and gentlemen, listen up, and listen up now for the first time. Listen up. When medications with addictive properties are prescribed for an individual, it is not uncommon for the individual to develop physical dependence without engaging in the maladaptive behaviors that will define an SUD. For example, a patient with cancer is prescribed an opiate for pain, and they may develop a physical dependence even when the opiates are used as they are prescribed, meaning that I have pain or my patient has pain. They are a cancer patient. And so maybe we are giving them 2 milligrams of morphine to control their pain. Sooner or later, either as the disease progresses, as they become accustomed or tolerant, develop tolerance to this 2 milligrams. 2 milligrams is no longer going to control their pain. Or if we were giving them 2 milligrams every 4 hours. Now what is happening is that the 2 milligrams is only lasting for 2 hours or 3 hours, and then now the pain is returning. And so that means that they have developed a tolerance. Okay, so what happens is for this patient, for this population, what we need to do is either increase their medication or shorten the time. Meaning, instead of giving the morphine every 4 hours, I'm going to give it every 3 because their pain is returning. Careful assessment and interprofessional collaboration are essential for an accurate identification of clinical manifestations of physical dependence and for determining the appropriate plan of care. If an individual on prescription pain medication develops tolerance to the prescribed medication, modification of the medication dose or frequency of dosing to adequately control pain may be required. This means that we need a conversation with doctor. This means that the patient also needs to have a very honest conversation with their physician. The same individual may require further assessment to identify and address an SUD if symptoms are present that suggest the presence of an opioid use disorder. So what does this mean? This means that after this very honest conversation with hopefully the patient being very, very honest and the healthcare provider being very, very open to what the patient is saying, maybe now we need to develop a new plan of care because we're not just going to keep on handing you opiates. We're not going to do that. The development and manifestation of an SUD is influenced by genetic, psychosocial, and environmental factors. Common substances associated with hazardous or harmful use will include alcohol, tobacco, illicit drugs, including prescribed medications that are used for non-medical purposes, just because. I want to take this Percocet just because. I want to take this oxycodone just because. In the United States, alcohol is the most used drug. Tobacco and marijuana are now close seconds. Ladies and gentlemen, please listen up, and listen up now. On page 1720 and 1721, table 70.2, there is a list, an extensive list, I will admit, of the commonly used addictive substances. Please know those commonly used addictive substances. You will see them in life, you will hear about them, you will see them in your nursing career and in your nursing practice. Even with legal drugs, the pattern of use by individuals who use these substances will frequently meet the criteria for a substance or alcohol use disorder. Although the legal drinking age is now 21 throughout the United States, there is a high prevalence of alcohol use among individuals between the ages of 12 and 20. So we are now starting with these behaviors quite early. In 2020, 6 million people between the ages of 12 and 20 used alcohol in the past month. In 2020, the National Institute on Alcohol Abuse and Alcoholism's National Survey on Drug Use and Health, otherwise known as the NSDUH, reported illicit drug use information related to the use of marijuana, cocaine, heroin, hallucinogens, inhalants, and methamphetamines, as well as the misuse of prescribed stimulants, tranquilizers, sedatives, and pain relievers. Among individuals 12 years of age and older, 59.3 million reported illicit drug use. The substance use outcomes of patient reports included data related to the use and the misuse of psychotherapeutic drugs available by prescription, including stimulants, tranquilizers, sedatives, and pain relievers. Misuse of these drugs is defined by the NSDUH as any use of these prescription drugs in any different way than as prescribed by the provider. Although marijuana is legal now in some areas, it is the most illicit substance. According to the 2020 NSDUH study, 49.6 million people 12 years of age or older used marijuana in the past year. Opioids will include chemically similar drugs, including heroin, and prescription medications such as hydrocodone, oxycodone, and morphine. In 2020, according to the NSDUH, 9.5 million people over 12 years of age misused opioids in the past year, and this includes the misuse of prescribed opioids. So, ladies and gentlemen, listen up, and then listen up right now, please, one more time. Central nervous system stimulants will include cocaine, methamphetamine, and prescription stimulants, and act on the brain in similar ways. So this is what I mean. By taking this substance and then by abusing this substance, meaning that I use it often, I am damaging my brain. The brain is now becoming sick. It is becoming diseased. So we need to remember that sometimes when we are talking to this patient, sometimes we are, and this will pertain to alcohol as well, we are no longer talking to the individual. We are no longer talking to the patient. What we are talking to is a diseased brain. Because if the brain was healthy and able to make a clear thinking decision, it might not choose this behavior. That's what I mean. We are talking to a sick individual. Stimulant effects of these drugs will include increased alertness, wakefulness, and energy, and physical side effects of rapid or irregular heart rate, increased blood pressure, and elevated body temperature, hyperthermia. So, I am going to use this substance. I'm going to take this drug. And then what's going to happen is I'm going to feel great. I'm going to feel very awake. I'm going to feel very, very alert. I'm going to feel very energetic. But because of this increased metabolism, well, now my blood pressure is going to go up. My heart rate's going to go up. There might be some tachycardia. There might be an arrhythmia. And I'm going to feel very warm, very hot, hyperthermia. Please continue to listen up, ladies and gentlemen. Genetics. Genetics will influence the risk of an SUD. What does this mean? This means that either by nature or nurture, if there is someone in the home or if there is someone in the family that has a substance use disorder, has an alcohol use disorder, there is a genetic component tied to that, meaning that this person is at risk for developing this disorder. Does that mean that they're going to? No. The same way if I am a diabetic and I have a child, does it mean that my child is at risk for developing diabetes? Yes. Yes, it is. This we know, right? But are they going to develop diabetes? No, they don't necessarily have to develop diabetes. Maybe they're going to live a healthier lifestyle. The risk is going to be there. The potential is going to be there. Their risk may be greater than another person's risk whose parent is not a diabetic. but there is a genetic component tied to this. Research will support a genetic component for nicotine, alcohol, cocaine, opioids, and cannabis use disorders. An individual with a genetic predisposition for an AUD or another SUD cannot develop a disorder if the person does not drink alcohol or use drugs. So this means that I'm the parent, and if I have an alcohol use disorder, if my child doesn't drink, or if my child only drinks socially and doesn't really go looking beyond socially, then no, they're not going to develop an AUD. They have to have that maladaptive personality as well. The interaction of biology and environment determines whether an individual will develop an SUD. So, excuse me, ethnicity, gender, education, and then mental health disorders. A person's ethnicity, gender, and level of education, and the presence of other mental health disorders are also associated with the risk of developing an SUD. Males are twice as likely as females to have an SUD. The prevalence of AUDs is significantly higher among men. Education is identified as a factor associated with the non-medical use of prescription stimulants. So, individuals with other mental health disorders are at much higher risk than the general population for developing an SUD by approximately 2 to 1. And the reason for this is because sometimes individuals will look to self-medicate. They don't, if they're feeling some kind of way, whether they're feeling depressed or anxious or experiencing an isolated event, maybe a separation or a divorce, move to another state and they don't have family support. So because of this, they don't want to seek out a mental health provider, right? Do I really need to go to my physician if I'm really depressed over a death in my family? Yes. Yes, you do. Because the mental health provider is going to guide you to healthier alternatives, right? They're not going to guide you to go to the nearest bar, or they're not going to guide you to go to your friend who may have a prescription for Xanax, and I haven't been sleeping because I'm so depressed. And well, here, borrow a Xanax, take a Xanax, and you'll sleep. Maybe you'll feel better. We're not going to do that, right? So, because this population may be experiencing some other things, they want to self-medicate, and this is why they will develop a an abuse disorder. Associated mental health disorders will include mood, anxiety, and personality disorders, some eating disorders, attention deficit hyperactivity disorder, otherwise known as ADHD, and conduct disorders in childhood, right? So I'm a child, I'm acting out, my parents don't understand me, they're not happy with me, so I'm going to steal their beer and drink. Age. A person's age at the initial use of an addictive substance is a strong risk factor for subsequent use issues. Adolescents' brains are still developing in the areas that govern decision making, judgment, and self control, so making them prone to risk taking behaviors, including trying addictive substances. The likelihood of developing an AUD quadruples if drinking begins before the age of 15. So, if we look back at the data that was compiled from 2020, now we can see that if someone is starting at 12 or even 13, by the time they get to age 15, they've already been drinking for 2 or 3 years. Research will demonstrate that teens with an AUD who smoke marijuana are more likely to go on to use drugs such as cocaine and heroin. Now, there are two schools of thought, depending on who you talk to. If you are talking to a research person will tell you that yes, marijuana is a gateway drug. If you are talking to someone who is a recreational user of marijuana, or maybe they're using marijuana for depression, or maybe they're using it for anxiety, maybe they're using it for recreational uses just to cope with life. It's the end of my day. It's the end of my work day, and it's now legal. And yes, this is what I want to do. They will tell you that no, it is not a gateway drug. So it really depends on who you're talking to. Stress is also strongly associated with the development of SUDs, with events in childhood being a significant risk factor. So, a child who sees their parents coping by using a substance, whether it's alcohol, a prescription med, a non prescription med, and this is their coping mechanism, this is what they learn. So, when they are dealing with stress, this is what they're going to look for because this is what mom and dad did. The use of alcohol is also increasing among adults 65 or older. And this is because, again, self medicating. My spouse has passed away. And so, because my spouse has passed away, I'm a little depressed. So, the one drink that I had with my spouse, like either before dinner or during dinner, maybe after dinner, maybe now isn't working anymore. So now I'm going to have two. Or my spouse has passed away and I'm very lonely and now I need to be more social. So I'm going to go out more. And the people that I'm socializing with, the people that I'm seeing, we go out to dinner or we go out to lunch and they have drinks. And so I'm going to drink. The method of administration of a drug also increases its addictive potential. Smoking a drug or injecting it into a vein allows the drug to enter the brain within seconds, So now, this is what I want you to think about. Think back to semester number 1 when you were in medication administration lab. And we were learning and talking about injecting a medication, whether it's a pain medication or whether it's insulin to bring down a blood sugar or whatever it is that we are injecting into this vein. Remember how we spoke about how there is no barrier. There's no barrier, meaning that whatever I put into this vein, my patient is going to feel immediately. It's not like giving them a tablet, or it's not like giving them something sub-Q, right? Where I can offset that. So if I go in and I give somebody a tablet, even with all the safety measures that we have in place, if I go in and if I give somebody a tablet and then I realize, oh my God, I gave them the wrong medication, I still have time. I can reach out to doctor and I can say, oh my gosh, I'm so sorry. What do you want me to do? Or if I've given them something sub-Q, maybe I've given them too much heparin, maybe I've given them too much insulin. What do you want me to do? There is something that we can do in the moment. Once you have injected something into that circulatory system, there is no going back. I hope you remember that we spoke about that. So now, a substance abuser, the same principle applies. They are ejecting this into their vein. There is no going back. And so it is going to go into the circulatory system and it is going to reach their brain within seconds. So again, please understand, we are dealing with a sick individual whose body is not only ill, but their brain is also ill. One of the simplest reasons, if we are talking about psychosocial risk factors, one of the simplest reasons that people use drugs and alcohol is to experience euphoria. I want to feel better. Most addictive substances will produce intense feelings of pleasure, making them highly desirable. I've done it. It makes me feel good. I want to do it again. Depending on the substance, the associated feelings can be those of power, increased self confidence, increased energy, or a sense of creativity. Ladies and gentlemen, listen up, and then listen up one more time. For example, persons who use cocaine or other stimulants, such as methamphetamine, will often experience an inflated sense of self, and we call this grandiose behavior, an inflated sense of self. And they will describe feeling energized with increased alertness, and they feel as though they can take on anything and be successful. They are very self confident. People who use heroin or marijuana often feel very relaxed and mellow after the initial euphoria. Alcohol and other drugs are often portrayed as enhancing the enjoyment of social interactions, meaning that maybe someone who is a little shy or a little introverted, maybe after a glass of wine or after a couple of beers, they are more social. They don't feel as shy. They feel more confident. I can speak to more people. I feel like I have a better sense of humor. I can make people laugh. All of this. So many individuals find that the shared activity of using drugs or consuming alcohol with others makes them feel part of a group, which is socially enforcing. This can make stopping drinking or drugs more difficult. Not only does the substance abuser have to give up familiar activities, locations, and established socializing patterns on the path to recovery, but friendship with individuals who continue to use may have to be relinquished, eliminated. Another reason people use drugs is to simply feel better. Significant associations are found between SUDs and co occurring mental health illness, including mood, anxiety, and personality disorders. The term self medicating refers to individuals who use drugs to cope with genuinely difficult issues such as stress, trauma, and the symptoms of mental health disorders. It is important to remember that these drugs are not prescribed medications, and they frequently exacerbate the very conditions that they are being used to relieve. Just as some individuals use drugs to feel good or to feel better, others use them to be their best. With increasing pressure on individuals to achieve more in the classroom or in their work life or in sports, more individuals are using drugs to enhance their cognitive and athletic performance. So, ladies and gentlemen, listen up, and then listen up one more time. We are talking about how psychoactive drugs will affect the brain. To understand how an SUD can be considered a disease, the nurse must appreciate the intricate communication system going on inside the brain. To function normally, the brain must maintain a careful balance of neurotransmitters. These small molecules will carry messages between nerve cells, otherwise known as neurons, to help regulate the body's function and behavior. Psychoactive drugs are chemicals that, in one way or another, will tap into this communication system and disrupt the way the neurons usually send, receive, and process information. This is the neurochemistry of the brain. So please understand that these psychoactive drugs are disrupting the process, the chemistry that is in a healthy brain. There are two ways that drugs can do this: by imitating the brain's natural chemical messengers, these neurotransmitters, or by overstimulating the reward circuit of the brain. Researchers found that marijuana and heroin can activate neurons because they have a structure like that of a natural transmitter and are able to fool the brain's receptors, causing abnormal messages to be transmitted. So these substances, marijuana, heroin, they are disrupting the neurochemistry of the brain. Fundamentally, all drugs of abuse, including nicotine and alcohol, will stimulate a common reinforcement pathway, the pleasure reward pathway. Directly or indirectly, these drugs will target the brain's reward system by flooding the circuit with dopamine. Dopamine is present in regions of the brain that will control movement, emotion, motivation, and feelings of pleasure. The dopaminergic system, normally responds to natural behaviors that are linked to survival, such as eating or spending time with loved ones, meaning that in a healthy person, I can do something naturally to increase my dopamine level, and that will bring pleasure to me. Sometimes it's reading a book, sometimes it's going for a walk in nature, sometimes it's being at the beach, sometimes it's being with someone that you truly care about. I truly love being with this person. So when I am with this person, my dopamine level would rise because I truly love this person and love spending time with them. So what happens is that when we go looking for an artificial way to increase our dopamine level, we are looking for a substance to give us this pleasure. The overstimulation of the dopaminergic system, which produces euphoric effects, sets in motion a pattern that will teach people to repeat the behavior of abusing drugs. So, if we take an athlete, a runner who experiences that euphoric feeling, that runner's high, right? So that drives them, that motivates them to run more. Or an athlete who is experiencing this feeling from whatever sport they're involved in. By abusing a drug, if I can simply achieve this feeling by abusing a drug, I'm going to do that more and more. As a person continues to abuse drugs and alcohol, the brain will start to adapt to these chemical changes by producing less dopamine. So the body is now producing less, which means that, oh my gosh, in order to feel good, I have to give it more. As a result, dopamine's impact on the reward circuit is lessened, reducing the abuser's ability to enjoy the drugs and the things that previously brought pleasure. So this means I now have to use more. This conditioning leads individuals with an SUD to experience an uncontrollable cravings when they see a place or a person they associate with the drug, experience, or trigger, even when the drug itself is not available. With ongoing exposure, the brain may become insensitive to the effects of the drugs or the alcohol. This, in turn, can cause the individual to require larger amounts of the drug. We call this tolerance, to achieve the euphoria or the dopamine high. Glutamate is a neurotransmitter that will influence the reward circuit and the ability to learn. So alteration of the glutaminergic function by an SUD can impair cognitive function. Brain imaging studies of individuals with one or more SUD will show changes in areas of the brain that are critical to judgment, decision making, learning and memory, and behavior control. Together, these changes can cause a person with an SUD to seek out and take drugs compulsively despite adverse consequences. And this is when we have left dependence and we have left tolerance, and now we are in addiction. And so you're talking about alcohol. And so we're going to talk about the categories of alcohol use. Alcohol can be defined by the pattern of use and amount consumed. So, for example, is it binge drinking? Is it heavy drinking? Or by the number of symptoms and consequences that are associated with its use. So, for example, are the consequences mild, moderate, or severe? So the amount of alcohol consumed and the pattern of use are also indicators of an individual's risk. So for example, low, moderate, or high risk of developing an AUD. So, according to guidelines that are developed by the National Institute on Alcohol Abuse and Alcoholism, persons at risk for developing an AUD are as follows: men who consume more than 4 drinks on a single occasion, men who consume more than 14 drinks in a week, women who consume more than 3 drinks on a single occasion, and women who consume more than 7 drinks in a week. So the reason women require less alcohol to be at risk for AUD is twofold. First, women have less body mass, and second, women's bodies are affected differently by alcohol than men's bodies, and there are reasons for this that go beyond size. Scientists have discovered that women produce smaller quantities of an enzyme, alcohol dehydrogenase, ADH, which is released in the liver and breaks down alcohol in the body. Therefore, women do not metabolize alcohol as effectively as our male counterparts. Alcohol is a CNS depressant that will affect several areas of the brain. So again, we are back to the neurochemistry in the brain. When alcohol reaches the brain, it will interfere with communication between the nerve cells by interacting with the receptors on some cells. Alcohol will enhance inhibitory nerve pathway activity, which has the effect of making a person sluggish. Additionally, alcohol will reduce excitatory neurotransmission by enhancing sluggishness. What does this mean? This means that the more I drink, especially if I'm a female, the more sluggish I am going to become. And so here is just on this side is just a simple picture of the brain and the things that are affected in the different areas of the brain. So moving on to the clinical effects of alcohol. Although the entire brain is affected, the cerebellum, which is responsible for balance, coordination of movement, and the frontal lobes, which are responsible for cognition, memory, thought, and learning, are most heavily affected by alcohol consumption. The short-term effects of alcohol vary based on several factors, such as a person's size, the setting that they are drinking in, the amount and time of consumption, hydration levels, and whether a heavy meal is being consumed. In general, in low doses, alcohol effects include euphoria, mild stimulation, relaxation, and lowered inhibitions. In higher doses, alcohol will cause drowsiness and symptoms of intoxication, such as slurred speech, decreased reaction time, further disinhibition, nausea, vomiting, emotional volatility, loss of coordination, visual distortions, impaired memory. Nystagmus, if we remember, nystagmus is involuntary eye movement. An unsteady gait, sexual dysfunction, and loss of consciousness. So both the quantity of alcohol ingested and the rate of the rise of the BAL, remember the BAL is the blood alcohol level. This will determine the level of intoxication. Blackouts are intervals of time for which the intoxicated person cannot recall key details of events. The long-term effects of alcohol abuse are associated with a wide range of physical and mental health disorders, including liver and heart disease, hypertension, risk for infectious diseases, nutritional deficiencies, depression, certain cancers, and AUD. Women who consume less alcohol and for a shorter period than men are at a higher risk of developing alcohol-related health problems. So, the metabolism of alcohol. Once ingested, the liver will secrete an enzyme, alcohol dehydrogenase, breaking down alcohol into an even more toxic substance, acetaldehyde. So remember, this is why men can drink more than women, because women don't break down alcohol in the same way. So the liver will convert acetaldehyde into acetic acid, reaching a saturation point where some of it will escape into the bloodstream. The accumulated acetaldehyde will exert its toxic effect by inhibiting the mitochondria, reactions, and functions. So the person who abuses alcohol is a victim of a vicious cycle. A high acetaldehyde level will impair mitochondrial function, metabolism of acetaldehyde into acetic acid, decreasing. More acetaldehyde will accumulate and cause further liver damage, such as causing the liver condition hepatitis or cirrhosis of the liver. Ladies and gentlemen, please note that on page 1729, there is a safety alert, and on page 1731, there is another safety alert. Please take note of those safety alerts and please know them. So the effects on the liver. So because of the liver's central role in detoxifying alcohol, it is significantly prone to damage. The stages of liver damage are 1, fatty liver, 2, hepatitis, and 3, cirrhosis of the liver. So fatty liver, these are changes in the metabolism of fats occurring, and they accumulate in the liver, causing liver enlargement and abnormal liver function. Please note, fatty liver shows rapid improvement with complete abstinence and a proper diet. Alcoholic hepatitis, the inflamed, enlarged liver. There may be some jaundice, pain in the right upper quadrant of the abdomen, high temperature, and alteration in structure and function of liver cells. This differs from infectious hepatitis A, B, and C, which are caused by a virus, if you remember. Once someone has had any form of hepatitis, they are at an increased risk for cirrhosis. And then there is cirrhosis. Cirrhosis is an advanced liver disease where functioning liver cells are replaced with scar tissue. Complications can include ascites, hepatic encephalopathy caused by ammonia not properly filtered by the liver and damaging the brain, and esophageal varices that will cause bright red bleeding and then eventually death. And then on page 1729, there is a safety alert relating to the liver. Please know that safety alert. The effects on the pancreas. The pancreas will secrete digestive enzymes and helps to regulate glucose. We know this. In pancreatitis, digestive enzymes will become thicker and more viscous, plugging their secretion to the digestive tract. These powerful enzymes begin digesting the pancreas itself, and this, as we know, if we remember, is a very painful condition. Symptoms will include severe upper left quadrant pain, nausea, vomiting, a low blood pressure, and high serum amylase and lipase values. The high sugar content of alcohol will increase the incidence of diabetes. Alcohol and pregnancy. Alcohol is a known teratogen, a substance that can harm the fetus. Fetal alcohol syndrome is a constellation of birth defects that will include poor growth, developmental delay, heart defects, and craniofacial abnormalities. Some age-related considerations. As a person ages, blood flow, metabolism, and excretion all diminish. In the older adult population, where health may already be deteriorating, alcohol will serve to cause new health concerns or exacerbate some old ones. Nutritional deficiencies. Because very heavy drinkers take in most of their calories through alcohol rather than food, a large percentage of persons with an AUD are found to have a deficiency in thiamine, which is vitamin B1, and folic acid. Long-term thiamine depletion in the brain can lead to serious CNS disorders, such as Wernicke-Korsakoff syndrome, which is a neurocognitive disorder. So, Wernicke-Korsakoff syndrome will consist of two separate syndromes: an acute, short-lived, severe condition called Wernicke's encephalopathy, and then a long-lasting, debilitating condition known as Korsakoff's psychosis. The clinical manifestation of Wernicke's encephalopathy will include mental confusion, paralysis of the nerves that will move the eyes, and difficulty with muscle coordination. Korsakoff's psychosis is a chronic and debilitating syndrome characterized by a persistent learning and memory problem. Okay, so ladies and gentlemen, we are going to be talking about withdrawal symptoms. And so please, I want you to listen up, and then listen up one more time. Almost all people with an AUD who have been chronic drinkers will experience some level of withdrawal symptomology if they suddenly stop drinking or significantly decrease the amount of alcohol that they consume. So the clinical presentation can range from tremors, anxiety, tachycardia, and irritability to life-threatening grand mal seizures and delirium tremens, which can include confusion, hallucinations, autonomic instability, and then possibly death. Ladies and gentlemen, please take note of this slide. So when the depressant effect of alcohol is removed, every mechanism will overreact within hours of the last drink, resulting in alcohol withdrawal syndrome. So on page 1731, ladies and gentlemen, listen up. On page 1731, there is a table 70.5, common findings of alcohol withdrawal syndrome. Please know those findings. So, treatment for alcohol. Various treatments are available to help people with an AUD, and depending on the circumstances, AUD treatment may involve a brief intervention, an outpatient program, or counseling, some medications, or a residential inpatient stay. Specific treatment for alcohol withdrawal may be inpatient or outpatient, and many people with an AUD with mild to moderate withdrawal symptoms can be treated on an outpatient basis. So, ladies and gentlemen, please listen up, and then listen up one more time again. Some will need to be hospitalized in a facility that will specialize in detoxification and can provide close monitoring of vital signs and assessment of these withdrawal symptoms. Alcoholics Anonymous, otherwise known as AA, plays a major role in the treatment of AUDs nationwide, and this has proven to be an extremely effective treatment approach. Currently, there are only 3 medications that are approved by the U.S. Food and Drug Administration, otherwise known as the FDA, for the treatment of AUD, and this is Antabuse, Revia, Endopade, and Camprel. Please continue, ladies and gentlemen. Please continue to listen up. Antabuse was the first medication approved for the treatment of AUD and is used to discourage drinking by inhibiting acetaldehyde dehydrogenase. The patient becomes very ill from drinking alcohol, and this is an adverse reaction to acetaldehyde. Naltrexone works by blocking in the brain the high that people experience when they drink or take drugs such as heroin or cocaine. Ladies and gentlemen, please know these 2 medications and please know how they work in the patient's body and how they work in the patient's treatment program. Please know that. Acamprosate is the most recently approved medication for AUD treatment, and it works by reducing the physical cravings and emotional discomfort people will experience when they quit drinking. The exact mechanisms of actions of these substances that reduce cravings and drinkings is not known. Ladies and gentlemen, please listen up. On page 1731, there is a safety alert. Please know that safety alert. So, we are talking about sedative hypnotics. The sedative hypnotics, referred to as depressants, are a diverse group of medications that are generally classified based on their medical effects on the body. All will reduce the activity of the CNS, the central nervous system. Sedatives will cause a mild depression of the CNS, decrease excitability and anxiety, and have a muscle relaxing property sought by many abusers of these drugs. And hypnotics will induce sleep. The use of alcohol, which is also a CNS depressant, with these medication potentiates the effects of the medication and can lead to addictive and then dangerous reactions. Meaning, if I am going to drink and then take one of these medications, a sedative or hypnotic. Barbiturates. Barbiturates are defined as any group barbiturate acid used as medicine, as sedatives and hypnotics. They have considerable medical value, but can easily be misused. Chronic non-medical use of barbiturates causes a cumulative toxic effect on the CNS, and this is where the danger comes, because somebody may take one of these medications for non-medical use and not realizing, like, I took one, maybe one's not enough, 2 is always more. No, 2 is deadly. Ladies and gentlemen, please listen up, and listen up one more time. Barbiturates are still used as anticonvulsants and anesthetic agents and have almost entirely been replaced by the benzodiazepines as legitimate medications used in the treatment of anxiety. Because of the potential for barbiturates to cause respiratory depression, they are much more dangerous in cases of overdose. Opiates and opioids. Opiates are narcotic analgesics that are derived from the opium poppy plant grown in Asia, Central, and South America. The term opioid refers to narcotic analgesics that are either semi-synthetic or fully synthetic, but can also refer to the entire family of both opiates and opioids. Morphine and codeine are both considered natural opiates. Semi-synthetic opioids include hydrocodone, otherwise known as Vicodin, hydromorphone, otherwise known as Dilaudid, meperidine, something that we really don't use a whole lot, and that is Demerol, oxycodone, Percocet, Percodan, and Oxycontin, and the highly addictive drug heroin. Synthetic opioids are fentanyl, like the Duragesic patch, propoxyphene, Darvon, and pentazocine, otherwise known as Tauin, and methadone. Fentanyl is a powerful synthetic opioid that is 100 times more potent than morphine and 50 times more potent than heroin. Like morphine, prescription fentanyl is used to treat patients with severe pain, especially after they've had a surgery. It is also used to treat patients with chronic pain who are physically tolerant to other opioids. So, when prescribed by a healthcare provider, fentanyl can be given as an injection, a patch that is put on the patient's skin, or as a lozenge. Opioids will reduce the intensity of pain signals reaching the brain and affect the brain areas controlling emotion, which will diminish the effects of the painful stimulus. They can produce drowsiness, mental confusion, nausea, and constipation, and depending on the amount taken, they can also depress respiration. These drugs also produce feelings of euphoria, relaxation, and contentment, and this is what makes them highly addictive. Consequently, there is a high potential for non-medical use of opioids and the development of an opioid use disorder. So, ladies and gentlemen, please listen up, and then listen up now on page 1735, table 70.6. Opioid withdrawal symptoms, you will know those symptoms. And then prescription narcotics. These medications are commonly prescribed because they are extremely effective for the treatment of pain. Because of their common use, most abusers can get them from family and friends or directly from their healthcare providers. In recent years, among young adults and older adults who use prescription opiates, 27% obtain them through a prescription from their healthcare provider. Other sources will include friends or relatives for free, 26%, buying these medications from friends or relatives, 23%, or buying from a drug dealer, and that is 15%. In addition to non-medical use, many people are being exposed to a prescription opiate legitimately to treat pain due to an aging population and more sports-related injuries in the younger population. The consistent use of prescription narcotics can lead to physical dependence with characteristic withdrawal signs. Tolerance. may accompany the physical dependence, resulting in the need to take higher doses of the medication to get to the same effect. When this occurs, it can be very difficult for a provider to know if the patient is developing a drug problem or if they have a real medical need for the higher dose to control the symptoms. So, if the provider believes it to be a drug problem, the medication is discontinued, which can sometimes lead the dependent patient to seek out these opiates somewhere else. And then heroin. Heroin is a highly addictive drug that is processed from morphine and appears as a white or a brown powder or as a black, sticky substance. Like other opioids, heroin will depress breathing, and overdoses can be fatal. Users who inject the drug are at risk for infectious diseases such as HIV or AIDS and possibly hepatitis. Pulmonary complications may result from the poor health of the user, as well as from heroin's depressant effects on respiration. So, injecting heroin can also contribute to valvular infections due to the possibility of introducing bacteria into the bloodstream. It can also lead to collapsed veins, cellulitis, and abscesses. Repeated IV injections can cause vascular sclerosis and can lead the injectors to inject subcutaneously or intramuscularly. Resulting infections such as necrotizing fasciitis can lead to disfigurement or death. Because of the withdrawal syndrome that will develop when doses are significantly reduced or stopped, treatment for an opiate use disorder will begin with medically assisted detoxification using Suboxone, Buprenex in tapered doses. Suboxone is also gaining popularity as an effective maintenance medication to prevent relapse. It will produce less risk for overdose, fewer withdrawal effects when it is stopped, and a lower level of dependence than methadone. Ladies and gentlemen, please listen up, and then listen up one more time. Some chronic users may not respond to Suboxone and may require maintenance treatment with methadone. Methadone has been used effectively for more than 30 years to treat these opiate use disorders. It has a controlled release effect that will greatly reduce the addiction risk by blocking the action of the opiate, as well as reducing withdrawal symptoms and the drug cravings. Revia and Vivitrol will prevent substance users from feeling the effects of the drug. So in 2017, the FDA approved the NSS2 bridge device to treat opioid withdrawal. This is a tiny electrical nerve stimulator that is placed behind the patient's ear. A battery-powered chip will emit electrical impulses to stimulate the branches of certain cranial nerves, and these stimulations may provide relief from opioid withdrawal symptoms. The device is used during the acute withdrawal, physical withdrawal phase. In 2018, the FDA approved Lucemyra for use in reducing symptoms associated with opioid withdrawal in adults. Lucemyra is indicated for the mitigation of opioid withdrawal symptoms to facilitate abrupt opioid discontinuation, in adults. In cases of life-threatening overdose, Narcan is used to counteract the effects of the opiate. It reverses the respiratory depression and has the effect of triggering immediate withdrawal. So the best treatment outcomes for opiate use disorders are achieved when available medications are used in conjunction with behavioral and cognitive therapies. Cocaine. Cocaine is one of the most addictive recreational drugs available. Cocaine is a Schedule II drug, meaning that it has a high potential for abuse, but can be administered by a provider for legitimate medicinal purposes, for example, as a local anesthetic for eye, ear, and throat surgeries. The mechanism of action, like that of other substances of abuse, is related to its ability to modify the action of dopamine in the patient's brain, which is the pleasure reward pathway. Cocaine will promote dopamine transmission by binding to a protein called the dopamine transporter, which in turn inhibits the removal of dopamine and ultimately leads to increased activation of the dopaminergic reward pathway. This increased activation will lead to the feeling of euphoria and the high that is associated with cocaine use. Cocaine will provide a reward that the user learns to obtain in the most efficient manner possible. Unlike learning to obtain natural rewards such as food, sex, or social cooperation, cocaine will result in a pathological form of reward seeking and ultimately takes precedence over adaptive social and personal behaviors. Cocaine's reinforcing value will impel repeated drug use. Studies have demonstrated that animals will work very hard for cocaine, such as pressing a bar 10,000 times after a single injection of the drug. So these animals chose cocaine over food and water and will take lethal doses if the supply is not limited. So, ladies and gentlemen, please listen up, and then listen up one more time. The increased energy and mental alertness and the feeling of grandiose and exhilaration in acute cocaine intoxication can quickly turn to the patient being irritable, agitated, and restless. The euphoric state is going to be replaced in short order by withdrawal, and this is characterized by anxiety, paranoia, depression, and suicidality. These contrasting mood states signal the brain to use more because the brain wants to regain the high. Please, ladies and gentlemen, please continue to listen up. Cravings for the drug are a cardinal feature of cocaine disorder and are a significant because of the potential to trigger use and then relapse. The complications that are associated with chronic use of cocaine are varied, with virtually every organ system is affected by chronic cocaine use because of the vasoconstriction and neural death that occurs. Cocaine abuse has been associated with cardiovascular system, meaning hypertension, tachycardia, and an arrhythmia, the pulmonary system, neurological, infectious, gastrointestinal, hematological, and obstetrical complications, as well as homeostatic disturbances. The method of administration of cocaine will strongly influence the pathophysiological process that will develop in the person using cocaine. Respiratory complications associated with smoking can range from exacerbation of asthma or wheezing to pulmonary edema, acute respiratory distress syndrome, bacterial pneumonia, pneumothorax, and pneumonitis, or something when the patient is using cocaine. We call this crack lung. Intranasal cocaine is responsible for atrophy of the nasal mucosa, rhinitis, rhinorrhea, bleeding, loss of the sense of smell, and vasculitis. So, cocaine treatment. The current treatment for cocaine use disorders is primarily focused on the psychosocial modes of cognitive behavioral, motivational, and rewards therapy, combined with support groups and counseling. Pharmacological treatment for cocaine use disorders has proven challenging over the year, and to date, no medication with proven efficacy is available for the treatment of cocaine or stimulant use disorders. More recently, a cocaine vaccine that would block the effects of cocaine has been studied, and it does show promise for relapse prevention when used in combination with more traditional psychotherapeutic models. Methamphetamine, otherwise known as MA, is a highly addictive psychostimulant that is proven to be a serious worldwide public health problem. Methamphetamine can be synthesized at home using a straightforward one-step process of reduction of ephedrine, such as um, neosyn something nasal spray. Neosynphedrine nasal spray, I believe it's called, for cold sinus relief, or pseudoephedrine, otherwise known as Sudafed, making it easy and inexpensive to produce. Sorry, wasn't exactly sure about my over-the-counter medications there. There has been an expansive proliferation of mom and pop meth laboratories along with larger criminal super labs that has led some regions to have epidemics of MA use disorders. The most predominant form of MA currently consumed, D-methamphetamine hydrochloride, is also the most potent with the purity level often above 80%. Methamphetamine's high purity level, combined with the almost immediate onset of effects produced by inhalation or injection, can quickly lead to the development of an MA use disorder. Methamphetamine effects. So, methamphetamine acts on the brain's reward pathway like no other substance or pleasure generating activity, with a twofold mechanism of action that causes an extreme surge in dopamine of almost 3.5 times the amount produced by cocaine and 12 times that produced by sex. In addition to blocking the reuptake of dopamine, like cocaine, MA stimulates the release of dopamine and other catecholamines in the CNS, resulting in levels of dopamine that are about 1,200% more than the baseline level found in a normal brain. Methamphetamine also has a significantly greater elimination half-life, 8 to 13 hours, than any other psychostimulants, such as cocaine, which has a half-life of 1 to 3 hours, leading to behavioral and psychological effects that will last substantially longer than those of other drugs. It can take up to 2 days to eliminate a single dose. MA also has a high lipid solubility, allowing more rapid transfer of the drug across the blood-brain barrier. The acute effects of MA are like those of the stimulants. However, MA can increase energy to the point that users feel superhuman, making it particularly appealing. The enhances of the sexual experiences that many users report, put individuals at increased risk for contracting sexually transmitted infections, including HIV. There is significant morbidity associated with acute and chronic MA use, including respiratory, cardiovascular, renal, and infectious complications. So, many MA users rapidly lose their teeth, a condition known as meth mouth, that is caused by a combination of dry mouth, poor oral hygiene, consumption of high sugar beverages, and bruxism. Bruxism is a fancy name for people who grind their teeth. MA exposure in utero has been associated with low birth weight and cognitive deficit in infants. Unlike cocaine use, long-term MA exposure has been shown in numerous studies to result in extensive neural damage that is associated with deficits in attention and memory. So, this neurotoxicity, again, because we are talking about the neurochemistry of the brain, so this neurotoxicity plays a critical role in the individual's inability to regulate and control the use of the drug. There is a strong psychological dependence associated with MA use, along with substantial evidence that heavy use can lead to progressive social and emotional deterioration. So, methamphetamine treatment. Many medication trials have been tried over the years to identify pharmacotherapy treatment for MA use disorders, all with inconclusive or negative results. Second generation atypical antipsychotics and agents that increase dopamine levels are being studied along with other more diverse approaches. The treatment of MA complications is primarily supportive and needs an interprofessional approach. The effectiveness of psychotherapy and behavioral treatment has reliability demonstrated a clinical benefit with minimal potential for side effects. So, MDMA. MDMA or ecstasy is a synthetic psychoactive drug that is like the stimulant MA and the hallucinogen mescaline. In a 2016 annual survey of teen drug use by the National Institute on Drug Abuse, otherwise known as NIDA, 2.7% of 12th graders, 1.8% of 10th graders, and 1% of 8th graders have already reported using MDMA. So, ladies and gentlemen, listen up, and then listen up one more time, please. We are talking about MDMA effects. MDMA is usually taken orally as a capsule or a tablet. It produces feelings of emotional warmth, euphoria, and an increased energy along with distortions in time, perception, and tactile experiences. As opposed to dopamine, serotonin is the neurotransmitter that is primarily affected by MDMA. MDMA also influences the neurotransmitter norepinephrine, which can cause an increase in blood pressure and pulse. Like other drugs of abuse, MDMA can be dangerous to overall health and can be lethal at times. Ladies and gentlemen, please take note of this slide. Ladies and gentlemen, please listen up and continue to listen up. The increased blood pressure and pulse caused by MDMA will increase the cardiovascular risk. In high doses, MDMA can interfere with the body's ability to regulate temperature, which can lead to a sharp increase in hyperthermia and result in liver, kidney, and cardiovascular system failure or death. So now let's get to the care plan of this substance abuse disorder. Medical management, screening, and interventions like other chronic relapsing diseases such as diabetes, asthma, or heart disease, SUDs, can be successfully managed. Effective treatment approaches include screening to identify the problem and interventions that are tailored to each patient's drug use patterns and particular strengths, challenges, resources, and their needs. For those who receive substance abuse treatment, the hospital emergency department, the ED, may serve as the initial entry point. The ED is an appropriate and convenient setting for immediate interventions and represents an access point for directing patients with SUDs to appropriate treatment programs. Nurses are well placed to provide interventions in the clinical setting that will capitalize on a teachable moment and a window of opportunity. As with other chronic diseases, it is not uncommon for a person to relapse and begin again using drugs. Ladies and gentlemen, please listen up, and then listen up one more time. Relapse does not signal failure. It indicates that treatment needs to be reinstated or adjusted, or that alternative treatment is needed to help the individual regain control and then recover. So to be effective, again, to be effective, treatment does not need to be voluntary. Sanctions or support from family, employers, or the criminal justice system can increase treatment entry, retention rates, and the ultimate success of drug treatment interventions. Screening. Research has demonstrated that screening for substance use combined with brief interventions in primary care settings can be cost effective, practical to use with people at risk and those with actual drinking problems. Screening, brief intervention, and then referral to treatment, and this is called SBIRT, is an example of an evidence-based approach. Screening followed by 3 to 5 minutes of simple advice from a healthcare professional helps many patients reduce their drinking. The website of the Substance Abuse and Mental Health Services Administration, otherwise known as SAMHSA, of the U.S. Department of Health and Human Services has information on SBIRT training and related services. Screening tools and approaches will include the following: SBIRT, the CAGE questionnaire, and then Audit C. So screening, brief intervention, and then referral to treatment. So implementation of the screening, brief intervention, and referral to treatment is designed for early identification of individuals with an SUD. The SBIRT approach is suited to identify individuals at risk for substance use disorders and to plan early interventions. The brief intervention will focus on increasing insight and awareness regarding substance use and motivation toward behavioral change. So, ladies and gentlemen, listen up, and then listen up one more time. Emergency departments, trauma centers, primary health clinics, and other community healthcare venues will provide opportunities for early intervention with at-risk substance users before more serious consequences can occur. Screening will assess the severity of substance use and identifies the appropriate level of treatment. So those individuals deemed to be at risk receive a brief intervention that will focus on raising their awareness of substance abuse and motivating them to change their behavior. So patients who need more extensive treatment will receive referrals to specialty care. Research has demonstrated that SBIRT is effective and that approaching patients during that teachable moment of their hospital or primary care visit will help change their drinking behavior. So the CAGE questionnaire. The CAGE questionnaire is a widely used tool for assessing alcohol use. So one yes answer will suggest that the patient needs closer assessment. Two yes answers is highly correlated with AUDs. So, ladies and gentlemen, please listen up, and then listen up again. On page 1740, box 70.6 is the CAGE questionnaire, and you will become familiar with the CAGE questionnaire. And then Audit C. Audit C is a standardized 3-question tool that focuses on consumption and evaluates the severity of alcohol use. Treatment approaches and individual programs will continue to evolve and diversify. Approaches will involve pharmacotherapy, detoxification, and treatment of acute withdrawal symptoms, maintenance therapy, and relapse prevention that will include 12-step programs, behavioral therapy, motivational interviewing techniques, and counseling. There also needs to be a comprehensive substance abuse treatment approach that treats not only the abuse disorder, but any other comorbidities that will complicate the patient's recovery. So, ladies and gentlemen, please listen up, and then listen up again. On page 1742, table 70.7, common disorders and complications that are associated with substance use or substance use disorder. Please become familiar with that table. You will need to know that table. And then nursing management. With an understanding of common risk factors associated with SUDs, clinical manifestations of commonly used addictive substances, symptoms of intoxication, and withdrawal issues, nurses are prepared to identify at-risk individuals and use the information to individualize a plan of care. To ensure patient safety when caring for persons with an SUD, it is important to consider the primary diagnosis and any other comorbidities or co-occurring SUDs and psychiatric or other medical diagnoses. Substance abuse causes, complicates, or coexists with other illnesses that may require admission to the hospital setting. The clinical manifestations of substance abuse are often subtle, caused by a comorbid condition or the substance abuse itself, and may not be recognized among the more obvious indicators of the admitting diagnosis. This is also complicated by denial on the part of the patient. So, ladies and gentlemen, listen up, and then listen up one more time. The cornerstone of assessment for substance abuse problems is establishing rapport and taking a thorough history from the patient and from outside informants, including family, friends, and any other provider. The nurse must communicate to the patient that there is no judgment, that information will be kept confidential, and that the nurse is there to help. Please, ladies and gentlemen, please take note of this slide. Please remember it. Please know it. Please practice it. Assessment and analysis. Clinical manifestations observed in the patient with SUDs may be related to intoxication, withdrawal, and longer-term physiological and psychological changes that are associated with specific SUDs. In some cases, The toxic effect of the substance directly damages body organs. Second, the route or method of administration may cause health problems. For example, the patient may have a skin infection. Third, lifestyle factors associated with substance abuse can cause illnesses, for example, malnutrition or poor hygiene. Increased risk or impairment in judgment while under the influence of drugs or alcohol may result in injuries or life-threatening situations that will require hospitalization. If a patient has participated in hazardous use of substances, there is a risk for withdrawal once use has ceased or dosages are decreased. Severe opioid withdrawal scales are available for identifying and quantifying the severity of opioid withdrawal symptoms. So, validated tools will include the following: the Objective Opioid Withdrawal Scale, which relies on clinical observation, the Opioid Withdrawal Scale, which records the patient's rating of opioid withdrawal on a 16-item scale, and the Clinical Opioid Withdrawal Scale, which includes 11 items and contains both objective and subjective signs and symptoms of opioid withdrawal. All nurses should have current working knowledge of usual intoxication and withdrawal symptoms and other health conditions that are associated with hazardous use and SUDs. So, ladies and gentlemen, please take note, listen up, and then listen up one more time. On page 1745, table 70.8, common indicators of intoxication, withdrawal, or other health concerns associated with substance use disorders. Please take note of that table. And then, ladies and gentlemen, please continue to listen up. We are talking about nursing diagnoses and the problem list. Alteration in comfort, physical pain or discomfort related to craving or withdrawal from substances. Sensory perception alteration related to withdrawal from the substance. Risk for injury related to withdrawal from the substance. Alteration in nutrition, less than body requirements related to poor dietary intake, secondary to drug or alcohol use, and decreased appetite with accompanying nausea, vomiting, secondary to the withdrawal. Ladies and gentlemen, please continue to listen up. Sleep pattern disturbances related to withdrawal from the substance. Anxiety related to the distress of withdrawal and absence of the usual coping mechanism. Hopelessness related to the chronic nature of the disease and possible past failed attempts at recovery. And then knowledge deficit related to the withdrawal process and treatment, recovery planning, and relapse prevention. Ladies and gentlemen, please continue to listen up. Nursing interventions and assessments, and we always start with vital signs. Increased pulse, blood pressure, and temperature may be signs of autonomic hyperactivity and indicate withdrawal. Vital signs are a useful index of the severity of substance withdrawal. Frequent monitoring is required to ensure safety, treat the withdrawal symptoms, and to promote comfort. And then the mental status examination. Withdrawal symptoms may be unpredictable. Changes from baseline may indicate increased severity or withdrawal or other physiological or psychiatric problems. Prompt response reduces the risk of worsening clinical manifestations. Comorbid psychiatric problems are common in persons who abuse substances. Patients withdrawing from substances may have impaired reality. Nutritional status. Albumin and total protein may be decreased. Vitamin deficiencies may be present, reflecting nutrition malabsorption associated with drug and or alcohol abuse. Blood alcohol and drug levels determine the substance used and the risk for substance withdrawal. The alcohol level may or may not be severely elevated depending on the amount consumed and the length of time between the consumption and the testing. These levels will provide an indication of tolerance and the risks for complicated withdrawal. Ladies and gentlemen, please listen up, and then listen up one more time. The complete blood count, the CBC. Decreased hemoglobin, hematocrit may reflect such problems as iron deficiency anemia or acute chronic gastrointestinal bleeding associated with chronic alcohol use. The white blood cell count may be increased with infections associated with drug and alcohol use. And then the glucose. Hyperglycemia, hypoglycemia may be present related to pancreatitis, malnutrition, or depletion of liver glycogen stores associated with drug and or alcohol use. And then serum electrolytes. Hypokalemia and hypomagnesemia are common with AUD. Liver function studies, creatinine kinase, lactate dehydrogenase, aspartate aminotransferase, and alanine aminotransferase. An amylase may be elevated, reflecting liver or pancreatic damage associated with drug and or alcohol abuse. Human immunodeficiency virus, hepatitis C virus, and tuberculosis testing as indicated. Infection with HIV, HCV, and TB is a possibility because of the risky lifestyle behaviors of individuals with an SUD. These disorders require treatment and may complicate withdrawal. Electrocardiogram. Dysrhythmias, cardiomyopathies, and or ischemia may be present because of the direct effect of alcohol on the cardiac muscle and or conduction system, as well as the effects of electrolyte imbalance. The chest X-ray may reveal pneumonia or chronic lung disorders associated with tobacco use, which is often associated with drug and or alcohol abuse. Because alcohol is a CNS suppressant, the cough reflex is suppressed, allowing secretions to pool, leading to potential respiratory infections. Smoking prevalence in alcoholics compounds lung problems, such as chronic obstructive pulmonary disease, pneumonia, emphysema, bronchitis, TB, and upper respiratory cancers, particularly those involving the lungs, the mouth, and the throat. Skeletal muscle changes, alcoholic myopathy, muscle atrophy due to nutritional deficits leading to weakness, cramping, and release of myoglobin resulting in dark urine can occur. Advanced aging in bones due to poor absorption of vitamins, calcium, and phosphorus is common. Megaloblastosis is a condition of abnormal RBCs due to folic acid deficiency that is combined with anemia. Peripheral neuropathy. Due to decreased absorption of thiamine in the patient who abuses alcohol, the myelin sheath covering nerves weaken, leading to slowing of conduction. Clinical manifestations include muscle weakness, pain numbness, and tingling, particularly in the legs. Wernicke's encephalopathy may develop, leading to confusion, severe amnesia, and personality alterations. CNS aging. Alcohol abuse will accelerate CNS wasting, observed in MRI scans that reveal larger ventricles and peripheral atrophy of the brain. So, ladies and gentlemen, please listen up, and listen up right now. A comprehensive medical, psychiatric, and substance use abuse history and physical exam. Establishing an appropriate diagnosis and determining if acute intoxication or overdose is present are essential in determining the appropriate treatment. To prevent AWS in hospitalized patients, nurses need to assess the pattern of alcohol abuse, medical and psychiatric problems that may have been masked by substance use. They may reappear. The CAGE questionnaire. 1 yes answer will suggest the patient needs closer assessments. 2 yes answers is highly correlated with an AUD. The Audit C. The Audit C is a standardized 3-question tool that will focus on the consumption and evaluates for the severity of alcohol use. And the CWA, CWA-AR. The CWA-AR is a widely used standardized assessment tool that will assess the presence of 10 symptoms of alcohol withdrawal, such as tremor and hallucinations. The higher the score, the more severe the withdrawal. It allows the nurse to identify and assess the severity of symptoms to intervene and medicate appropriately. SBIRT. The SBIRT approach is designed for early identification of individuals with an SUD or risk for SUD, early determination of the severity of identified SUDs, implementation of an appropriate level of brief intervention, and referral to the appropriate level of treatment. So, some nursing actions. We are going to establish and maintain an airway. This is required if the patient is acutely intoxicated or has overdosed. Excessive somnolence increases the risk of airway compromise. If vomiting is occurring with a decreased level of consciousness, there is an increased risk of aspiration. We need to provide adequate fluids and electrolytes. We will administer medications to treat withdrawal symptoms and specific SUDs as ordered. So for opioid use disorder treatment, lofexidine, we can use this for reducing symptoms associated with withdrawal in adults. Ladies and gentlemen, please take note of this slide. Listen up, and then listen up again. Methadone. This will bind with the opioid receptor with a controlled released effect that will greatly reduce the addiction risk while reducing withdrawal symptoms and drug cravings. Sublocade. This will provide less risk for overdose, fewer withdrawal effects when stopped, and a lower level of dependence than with methadone. And then Narcan. This will prevent substance users from feeling the effects of the drug. It is also used to reverse the respiratory depression that is seen with acute overdose. Ladies and gentlemen, I cannot stress this enough. Please know these medications. Please continue to listen up for AUD treatment. Antabuse. It works by causing a severe adverse reaction, nausea and vomiting, when a person taking the drug drinks alcohol. Revia will block the high that people experience when they drink or take drugs, such as heroin or cocaine. And then Camprol. This medication will reduce the physical distress and emotional discomfort people experience when they quit drinking. Multivitamins, folate, and thiamine. Individuals with an AUD have poor nutrition and may be deficient in thiamine and folate. Thiamine is essential for the metabolism of glucose. A patient who is deficient in thiamine is at risk for acute and chronic mental status changes that are associated with Wernicke-Korsakoff syndrome. Folate, crucial for the formation of red blood cells and protein metabolism, helps to treat or prevent anemia. And then promote adequate nutrition. Nutrition is especially important for individuals recovering from an SUD because they are likely to be nutritionally depleted because of poor diet or impaired absorption of nutrients. So, ladies and gentlemen, please listen up, and then listen up one more time. We need to maintain a calm environment with appropriate lighting. Excessive stimulation may exacerbate the effects of the patient in withdrawal. We need to establish rapport by using a non-judgmental, caring, and competent approach. We need to build trust and minimize resistance. We need to demonstrate acceptance of the patient as a worthy human being and one that is deserving of care. And then we need to provide psychological support and instill hope that successful recovery is possible. Consult a social worker, case management, or psychiatry to plan for longer-term treatment. Detoxification alone is insufficient for long-term recovery from substances. Ultimately, the goal is to prepare the person for entry into a rehabilitation program with the hope of long-term abstinence. So, teaching patient education for this population. We will educate the patient on symptoms and treatment of withdrawal, make the patient a partner in care. Signs may be subtle, and nursing may need to rely on patient report of symptoms. Disease process and general health education. Patients need to have an appreciation of physical, psychological, cognitive, and behavioral changes and conditions that are associated with drug use and SUDs. Recovery planning and relapse prevention education. Patients need to learn treatment options and ways to develop sober support systems that will facilitate long-term recovery. They need to learn ways to identify, avoid, and cope with triggers. Educate the patient on basic concepts of 12 steps and how to locate meetings in their area after discharge. It is important to understand what the 12 steps are and how they may support recovery. And stress management. It is important that the patient expands their repertoire of effective coping mechanisms to avoid destructive coping, such as drug use. And then post-acute withdrawal syndrome. The symptoms of PAWS may occur because the brain's ability to react to stress has been weakened by long-term substance abuse. Patients need to be aware of the signs and symptoms of PAWS, understand that it is a normal part of recovery, and learn ways to cope in order to maintain sobriety. Ladies and gentlemen, thank you so much for your time and attention with this topic. As always, if you have any questions, comments, concerns, please reach out. And I thank you again.